So welcome, everyone. We're going to get started. This is mostly our crew of medical physics students. We'll get faculty present as well. Our speaker today for the noon talk of the medical physics unit is Dr. Pia Wintermark. She and I have been acquainted for some time now, and I've known about her research and have kept abreast of it to some extent. Unfortunately, we don't collaborate yet that closely, but it would be something worth pursuing. Anyway, Dr. Wintermark is a pediatrician and neonatologist. That means she works with the newest of newborns and those who need the most help after birth. And she's accompanied here by one of her research group members, so we'll get a chance to chat somewhat after the meeting. Dr. Wintermark is from Europe, from Switzerland, and has trained both in Switzerland and in the USA, and then came to McGill and the Montreal Children's Hospital, where she has clinical work and academic work and teaches and trains and does all kinds of wonderful things. I invited her here because her research uses neuroimaging, but you'll see that it does far more than that. And I look forward to your presentation, and I'm sure the rest of you too as well. So welcome.
Thank you for the invitation. And yeah, exactly. The first apology is I'm not an engineer. So this is where I bring my student here and online. If you have more technical question, hopefully they can answer the question. I have no other disclosure. And the only thing is we'll discuss, sildenafil, which is off-label use for now in neonates for what we do, which is repair the brain. So I have to give a bit of background. So I'm a neonatologist, so I take care of babies in the NICU. There is mainly two types of babies in the NICU, the one born too much early, so that's premature baby. And there is a baby with hypoxic-ischemic encephalopathy. So it's baby that are born dead. And, as neonatologists, you go to the delivery, you hopefully resuscitate the baby in most cases. But then this baby is at risk to have damage to the brain. It's like a two process, you have the heat you get at birth, but also once you have succeeded to resuscitate the baby, the blood flow come back to a brain that has suffered, and that causes a secondary phase of injury to the brain. And so the only treatment that exists for now is therapeutic hypothermia. So you cool this baby to 33.5 degrees Celsius for 72 hours to try to prevent this reperfusion to the brain and avoid this secondary injury. And the problem, so it's preventive, it tries to protect your brain, has been shown in trial to reduce, a number of deaths and improve neurodevelopment. But it's not always successful, and up to 30% of the treated baby still develop damage to the brain. And in low and middle income country, we are not sure if it's efficient because, it's complicated to do hypothermia reliably for 72 hours there. And then the results are maybe not the same. And what is sure, it doesn't repair the brain. So once you have brain damage, you can continue the hypothermia, you will keep the same brain damage. So the idea was to find something else to offer to this kid that maybe we could improve the function and the structure after brain damage, and that would be helpful. So this is this difference between neuroprotection and neurorestoration. So neuroprotection, you have only a few hours to start the treatment, like a therapeutic hypothermia. A neurorestoration is repair of brain damage, and nobody knows exactly how long you are. You may have days, weeks, or longer. It seems that in adult, they are trying to work on that also. But obviously, an adult brain is different. I'm old. I'm losing my neurons. You guys probably are young, so it's still getting configured according to what you're doing every day. But baby is even more plastic because it's not mature at all. That's why a baby doesn't do much. And by 6 months, he starts, to sit down and all that is because his brain is still maturing. So you can probably use this plasticity to do something and improve their outcome. There is many, like you don't need to read this slide. There is many team around the world that are trying different treatment. Most of them, they try to prevent and add something before the reperfusion phase. We did a bit differently. We wanted to repair because I got frustrated to tell the parents, now you have brain damage and there is nothing more that I can do. So among the treatment to repair, it's mostly the one in the second part here for the repair phase. There is a few ones. There is stem cell that people are studying, but it's hard to find a good dose of stem cell and where they are from. There is erythropoietin that has been tested, but it didn't show as successful as it was, when they tested in baby. And there is sildenafil. So sildenafil, the other name is Viagra, most known for other things in life. But, the other side effects of Viagra are, that maybe it can repair the brain. And I will try to show you why. So we have also, we have an imaging lab, but we have a basic lab where we have little animals, rats, that we do the experiment. And we decided to do the same experiment as in humans. So on P10, which correspond to a term baby, we do hypoxia-ischemia, so it's carotid ligation with hypoxia for 2 hours so that they get a big hole in the brain, and that looks like the baby. And then we decided to give the sildenafil a bit like we will do in reality. So compared to all the other team that do hypoxia-ischemia and start the treatment right away to prevent, we say, okay, wait, we want to make sure the rats have brain damage. So we waited for 12 hours after the HI to make sure the damage process was ongoing to start the medication. And then we give twice a day for 7 days because typically the babies, they stay 10 days in the hospital. So we say, let's do the same in the rats. And then we try all the dose of the sildenafil we can use. So the smaller dose is 0.5 in a baby, and the higher dose is 3. So then you have to calculate that in rat metabolism, and that gives the 2 to 50. So this is what we got in the rats. We could do MRI also in the rats, but in this case, we took the brain and did histology. So here you can see brain of rat that didn't have hypoxia-ischemia, so this is what it should look like. This is one with hypoxia-ischemia only. So you see this big hole is due to the carotid ligation and hypoxia. And then you see free brain that received the increasing dose of sildenafil and where, the injury seems to get better. Obviously, you don't get one animal because it's like in human and there is lots of variability. So you get at least 10 in each group. And then we still seems to see the same trend, but with HI alone, the hemisphere ratio of the surface was lower and then seems to go up with the sildenafil. So we wanted also to look for the cell in the brain. So once you have hypoxia-ischemia, there is a lot of neuroinflammation. Neuroinflammation is astrocyte, GFAP, and is microglia, IBA1. So you can see when you have only hypoxia-ischemia, which is the second line here, and the first column here, your astrocyte and microglia come in the brain. They are the one causing the damage. They are very active, the shape. But we then noticed that with the dose of sildenafil going up, this number of cells went down. And same, they become unactivated again, which is better for our brain. And then we look different cell, but because here today is imaging, so I will not go over the different cell, but in summary, what we find is we think there is an effect on neuron. We have one student, doing a neuron culture. We think there is less neuron that die, but we think there is neuron that regenerate. And we are trying to demonstrate that. Microglia and astrocyte, I show you, decrease in number and, a decrease activation. We think it also work on myelination, so the oligodendrocyte with improving myelination. We don't think it's by the vasodilatory effect that is most famous from the sildenafil. because that will actually not be good because it will vasodilate a brain that has already too much blood flow. So that cause more brain damage. So we measure, in fact, in the baby with the ears, and we say that the perfusions stay the same. So that was reassuring. So what we're looking is the effect on the cell more than the effect on the vessel. So then the thing to know is sildenafil is, or Viagra, is very cheap. Everybody can buy it. You can have that everywhere in the world. So if it works, then it can go anywhere in the world. What I didn't say also is for the animal study, what we did is what we wanted to do also in the baby. We give everything by a gavage tube in the stomach. So you don't need an IV because sildenafil, you have two forms. You have one form that is IV, intravenous, and you have a form that you can eat. So because we wanted to make sure if it works, that it can go anywhere, doesn't need a nurse that places an IV in a small baby. We give by gavage, and that seems to work. And this medication, in fact, is used already in many babies around the world for the lungs. If you have persistent pulmonary hypertension, like too much pressure in your lungs, you can take this medication. But usually a clinician, very often, the one that like the lungs, they look at the lungs, they don't look at the brain, so nobody follow the development of this kid. So us, for the trial, this time we decide to apply to the HIE baby, and we have colleague that looks at the heart and lungs because we say, let's not lose an opportunity. We may make better the brain, but then we may, in the same time, make better the heart and the lungs of this baby that are also sick after hypoxic-ischemic encephalopathy. So this is how we organize the trial. So on day one, obviously the baby arrives in our unit. He needs to be asphyxiated to be enrolled in the trial, obviously, and he needs to have therapeutic hypothermia started. Then we bring the baby on day 2 of life, once while he is cooled, to the MRI. And then we do an MRI. If he has brain damage, then he's randomized to the treatment. If no brain damage, then you just follow the course, because what we want to do is repair the brain. So if you have no damage to be repaired, then no point to be in the study. We continue the treatment for 7 days. So we arrive at day 9, where we repeat the MRI. Now we do one after the cooling. So it can be any days, the one after cooling. And then we do another MRI on day of life 30, and you will see why. And obviously, then we follow them at 18 months or 24 months to see if we have an effect on the development. So each baby, in fact, becomes its own control because we have his day 2 MRI with the injury, and then we follow the evolution. So we had to do a few things that didn't exist, to make that possible. So first, we were told you cannot bring the baby during cooling to the MRI because your cooling machine is magnetic. So you may injure the MRI, and radiologists will be really unhappy. So we said, no problem, we'll find a way. So we took a pillow, put it in the fridge, freeze the pillow, freeze the blanket, and then we make sure it's not wet. And then we put them around the baby, and as simple as that, maintain the temperature of the baby for 1 hour. So we know on day 2, we can stay maximum 1 hour in the MRI. So as soon as we take the baby out of the bed, we have a timer, cannot be more than 1 hour, to make sure the brain doesn't get rewarmed, and the baby. What we did is we run this part of the study for many years while we were doing the lab experiment to see what it gives us. So we did the different MRI. We did, I haven't tried day 1 within the first 24 hours of life. But that was a lot of stress because you need to get the baby, you need to get the consent, and then you need to go to MRI and make sure radiology let you access the MRI. That was the hardest part, and it didn't reach enough sensitivity because by day 1, within the first 24 hours of life, you couldn't see the full extent of the damage. So it was a lot of stress and politics and everything for not what we wanted to reach. But by day of life 2, you can see, we see the full extent of the damage that we see after cooling. So then it becomes interesting because you know the full extent, you know it will not change, and we will see after. So the scan after the cooling show exactly the same. So now if you add a treatment, you know which one you can add the treatment. Then we did day 30 of life. So some people also tell us why you make this baby come back again, and you are again in our MRI. And yes, we say because if we add a treatment that repair the brain, you know, in the brats, we take the brain and see if we have repaired the brain. We cannot do that in babies. So the only way to do that is rescan them and see if we still see the same damage to the brain. So we did that, and in the baby that received no other treatment, on day 30 of life, it was very sensitive. You still see the same thing, which is good because then means if we give the treatment, maybe by day 30 we can see something. So we'll have to see. So we started the first study. It's called Sane 1 because in the NICU everybody is a bit insane. So that was a game, and then in addition, it works well with sildenafil administration to treat neonatal encephalopathy, so it matched. We did a double-blind, randomized placebo control. So 2 babies were receiving sildenafil for 1 baby receiving placebo, because we figure once they have brain damage, you know, parents obviously, placebo will do nothing. Sildenafil may do nothing. Or may do something. So obviously then at this point, everybody wants to try the thing that maybe do something and at least doesn't make it worse. So this is why we did 2 over 1. We were a bit scared to start with the full dose. You have seen in the animal lab that the biggest dose was the most efficient, but because they are on cooling, you know, the medication can accumulate in the body. So everybody was a bit scared that we start with 3. I have to say the only side effect of this drug is lowering your blood pressure, which the baby with HIE are already at risk, and have often medication for that. So first study is a phase 1, so it's very small. It's just to prove that it's feasible, that it's safe. And then we wanted to measure the sildenafil concentration in the blood to see if we reach something. So you can see, again, no need to read this, but we select the patient, you know, 79 patients arrive. We make sure to take the one that are the sickest, because obviously the sickest one are the one at risk to develop the brain damage. So all the mild HIE we remove. Then you needed to be enrolled in the study, and you needed to have a brain injury on the MRI, and then you were randomized. So you will see at the end, we had only 3 patients with placebo and 8 patients with sildenafil. There is 1 patient, parents decided to withdraw the care. So that happens often here and around the world. When they see full injury in all the brain, then parents are allowed to decide for that. And then we follow them up. And then we measure the concentration. As mentioned, there is no direct link between the sildenafil concentration and the effect, at least for the lungs. For the brain, nobody knows because nobody checked. So we figure if we reach 200 nanogram by milliliters is the concentration that has been in some case described with the pulmonary effect. So we would be happy. So you will see, while we were still cooling the baby, we reached that level. We are not too bad, but after that, it decreased drastically. So we were kind of disappointed. It's not surprising, it's because once you are out of hypothermia, your metabolism start to work, because that's the proper of hypothermia. You know, you're kind of low metabolism, then it start to work. And in addition, in the first week of life, the enzyme, you know, of the liver are starting to work. So even a normal baby, not cool, nothing, you know, his liver will start better working in the first week of life. So this is both effect that you see there, but this is disappointed because means after hypothermia, it's like you give nothing. So then we organize a second phase 1 study. This time we remove placebo because we figure we were taking a lot of blood to measure concentration. So it's not very nice to do that to a baby that received placebo. And then we give only sildenafil, and we went up to the dose of 3 milligram by kilo by day, which was the dose we wanted to reach with the maximal effect on the animal. Again, it was only in one center, small, just to make sure it's safe. And so you see it's a small number, 8 in group 1 that receive up to 5 milligram by kilo by day, and 5 in group 6. Then COVID hit, obviously, then we couldn't get the baby out of the room, and this was all a mess. So we also stopped there, because we had enrolled in both groups. We wanted the group 2 to have more number, but we stopped there because, to start the analysis of the result. Also in group 1, we had a few babies that had lower blood pressure with the medication, but they were all babies that had also a refractory seizure on medication for the seizure that caused the hypotension. And then in the NICU, they're on time schedule, so they give the antiepileptic 8 p.m., 8 a.m., and then 1 hour after that, the hypotension was starting. And this is when we were giving our sildenafil 9 p.m., 9 a.m. So now we are changing the time depending when he's receiving the anti-seizure. And then now we have no more blood pressure problem. And then this time we were happy. The sildenafil concentration went up, even to 300, and kind of stay not bad until the end of the treatment. So we think at least the body is seeing something. And now we are crossing our finger that maybe the brain is seeing something. So then I wanted to show you the first result because, now we started the phase 2, but to make sure we're allowed to start the phase 2, we have to prove that at least we didn't make the baby worse. So that's what we look. So first, this is the table of the characteristics. So you see the placebo and the free group of sildenafil. So if you're a clinician, the first thing you look is if your kid is sick from a cardiovascular point of view, that put him at risk at more severe brain injury. So our bad luck was that all the patients with sildenafil had a higher lactate, so more hemodynamically unstable. And the troponin and the creatinine kinase are the enzyme like we measure in cardiac infarct, in an adult. We can measure that in babies. And same, if they are elevated, means your cardiac function is not good. So you can see the number were highly elevated in the sildenafil one. So bad luck to us, our sildenafil baby were sicker and thus more injury. Then we also check their kidney because they can have kidney injury, and worse kidney injury get worse brain damage. So again, no luck there. They had worse kidney injury. So they were definitively at risk of more severe injury. And this is what we saw on day 2. We put also our historical group because some of the reviewer for the grant say, oh, but you have only 3 placebo babies, so you cannot conclude anything. We say, no problem. We can put the 154 baby that we scanned before on day of life 2, 10, and 30. And so we can use them as control because they receive no medication. And we have their follow-up, so we can compare with the one enrolled in the trial. So then our group placebo becomes bigger, and then we still have our group sildenafil. So you can see our bad luck makes that in the historical group, because you can enroll even if you have no brain injury, only a small number at the score of 3, 4. So like I have to explain the score. Score 0 is no brain injury. A score of 1 is basal ganglia injury, so the central structure of the brain. A score of 2 is white matter cortex injury. And a score of 3, 4, it means near total injury. So you have a basal ganglia, white matter cortex injury is 3 if it's not all the brain, and it's 4 if it's all the brain. So we group the 3, 4 together because that's called near total. And you see, obviously, in the historical, because we enroll baby without brain damage, only 31 and near total injury. In the placebo group, only 67, but in our sildenafil group, 88, 50, and 80%, which goes with the fact that they were sicker, unfortunately. So then we put together, so in neonatal trial, what they like to report is death and neurodevelopmental abnormality at 18 months. So we did. You can see if we look the baby that have brain injury in the historical control, 77% had this outcome, death of abnormal development. And to remind, they were less sick. 100% of the placebo, but now even if our sildenafil were sicker, 62%, 50%, and 60%. So that's interesting. Then we look at the MRI. So we come finally to the MRI part of the talk. And you can see, so we scan them on day 2 that are these first 3 columns. The first line is a baby that received only therapeutic hypothermia with placebo. And then the second line is therapeutic hypothermia and sildenafil. So you can see on day of life 2, before the treatment, these 2 babies have the same injury. They have injury in the basal ganglia. They have injury, which are dark gray here. And then on the diffusion weighted imaging is white. So they have injury in the white matter, cortex, basal ganglia. So they are a 4. They have injury everywhere. And then we follow them. Day 10 kind of looks similar between the two. Day 30, the one with only placebo has shrunk a lot, especially the basal ganglia. But the one with sildenafil, from a look, you can still see the basal ganglia. And then you see the 6 months, because we try to make them come back at 3 months and 6 months. Sometimes they don't collaborate as well with us and wanted to sleep just with a little milk. But we try our best. My students try their best. And so at 6 months, you can see this one has really shrink. This one, not so bad, has shrink, but not as bad. So again, you can say it's one animal, one baby, is the same. So maybe it doesn't reproduce. So what we did is we took the report of radiologist. Radiologist doesn't know if we give medication, do not give medication. And you can see, so in the historical control, 0% of baby had reduction of brain injury. In the placebo, 0%. In the sildenafil, 71%, 80%, and 67%. So we took at a reduction of brain injury if they could not see anymore some of the brain injury they see on day of life 2. If there was no less brain volume loss, because usually by day 30 they describe this brain volume loss that we see, or cystic transformation. So if they didn't describe that, then it was a reduction of brain injury. But again, you can say it's qualitative. And then we look at outcomes. So one of the important outcomes, especially if you have basal ganglia injuries, that you're at risk to develop cerebral palsy. So you can see historical group, 57%, 100% in the placebo group, even if they have less severe injury, and 17%, 0%, and 50% in the other group. So we still think we reduce something there. But obviously, it's for some small number. At least we are not making it worse. And this is the motor, cognitive, and language score at 18 months. So again, the number are too small to do statistic, but I'll let you see the result. So then what we did is very good from qualitative point of view. It looks better, but we are a bit bothered that it's only qualitative and that we cannot measure something as scientists. We like to measure things and see if what we see is real or just an impression. So what we did is we took all the baby that we had image, so the historical control, 154 baby, and then all the baby enrolled in the trial. And we grouped them in 3 groups. So first group is no brain injury. So in this one, you have the baby with HIE treated only with therapeutic hypothermia that didn't develop brain injury. And then we put also a few NICU nurses that were friends and volunteered their baby for us to have the scan. So we have a few LC term baby. In BI and TH group are all the baby with brain injury treated with therapeutic hypothermia only. And then in BI, TH, and S is the one treated with therapeutic hypothermia and sildenafil. And in this one, we group the 3 groups, even if they are different doses of sildenafil. So to know all of them didn't get the highest dose, but otherwise it will be a too small group to make a difference. So the first thing that we did by MRI is, we had this impression the basal ganglia volume was staying the same. So one way that we measure is we simply measure the area of the basal ganglia. And we did different region of the brain, but we show this one because this one is the one where we see well the effect. So you can see on day of life 2, you will find back your 3 groups. White is no brain injury, red is brain injury with only therapeutic hypothermia, and blue is with sildenafil. So you can see on day of life 2, and they start with the same basal ganglia. You don't see effect of HI yet. By day of life 10, both of them have decreased basal ganglia. By day of life 30, the one treated only with therapeutic hypothermia had not so much basal ganglia anymore to measure, like we had seen on the picture. The one with sildenafil, it was still decreased, but it was much better than the other one. So that's interesting because what we saw qualitative, then we could measure. And in this case, it's not one baby. You could see in this white group, there was 296 baby, 150 baby in the red group, and 21 baby with blue. So it's not anymore one patient, but it seems to be a trend. Then I have my student, Maria. She looked at diffusion tensor imaging. So as you guys know, you can measure fractional anisotropia, which is the microstructure of the brain, how the fiber get organized. So we decided, if we, by different sequence, we could look if we see this effect, because we had this effect on neuron, in the animals, on oligodendrocyte and all that. Can we see the same thing with MRI? So by day of life 2, you can see the baby again are the same. But by day of life 10, both baby seems to have impairment of fractional anisotropia. And by day of life 30, the one with therapeutic hypothermia definitively decrease. The ones with sildenafil a bit better. And again, looks significant compared to this group. So that's interesting, means the growth is better, the microstructure appears better. Then I have Hossein, who is online, who look at T2 star for myelination, because remember we said there was an effect on oligodendrocyte. So we know T2 star is myelination and also inflammation, but mostly myelination probably at that age. So again, you can see on day of life 2, both groups that have brain injury were already abnormal myelination. It persists by day of life 10. By day of life 30, it persists in the one treated with therapeutic hypothermia only, but it gets better in the one treated with sildenafil. So now we have 3 sequences that show a similar effect of improvement, repair, or whatever you want to call. And then finally, we took spectroscopy. Spectroscopy, you can measure metabolite. So one of the, the one that is more often measured in this baby is lactate over NIA, because they get lots of lactate for brain damage, which we had because they all had brain damage. But we decided to look at another ratio, that is NAA over creatinine, that could reflect the neuron. And then if we use different machine afterwards, by having the ratio, then we remove the effect of the machine. So you can see by day of life 2, both groups were abnormal. The sildenafil group were even worse in question of NAA. By day of life 10, it persists. But by day of life 30, the group with sildenafil is a bit better for the NA. So again, one more sequence. So now we are at 4 sequence, and that seems to show the same. And this one, this time, is not anymore qualitative, but quantitative that we could measure. So that was reassuring. We said it's feasible, at least in one center, to give sildenafil to this baby. It looks safe, especially if we'll time with the other medication. It was well absorbed. We think we could push until the maximum dose that we are allowed to use in this baby. And we think from the first MRI study that maybe it can repair the brain. So now we're working on the phase 2 study. And Yves has helped us start that last year when we started the MRI, and the MRI on our side was not there. So we started the first scan here to make sure we restart. This time we'll open other center. We want to show that it's feasible and safe in other center. And obviously, we want to try to see if we are efficient or no with a good number of babies. So this is the site. So we have Open Saint-Justine, but they have very few babies, so only enroll one for now. There's Quebec. They are waiting their new MRI, so hopefully after that they can start. Calgary, they are still doing paperwork. Edmonton, they nearly finished their paperwork. And then we wanted one site in the US, because if we can prove it's feasible in one site in the US, then we can go to the US, and it will not be on, it's only been done in Canada, doesn't work. So this is why we have Denver. They have nearly done also all the paper. We get FDA approval for that, and hopefully they can start soon. So that's it.
Things from the room here or questions online for our speaker?
Was too clinical.
No, absolutely not. Yeah, go ahead.
I was wondering if these therapies have been applied or like tested in, other people with different kinds of brain injuries, like perhaps like ischemic strokes or just like through types of traumatic brain injuries. Do you know if this treatment is feasible for them?
Yeah, so that's how I got the idea originally. I was a resident in Switzerland, and I read this article that in adult, they were trying sildenafil for stroke, Alzheimer, and multiple sclerosis. Like obviously, a brain of an aged person is not as plastic as a baby, but they are already encouraging results, And then, there come the idea, because it was but we use that drug every day in the baby for the lungs, but then nobody look at the brain. So that's how it started. Yeah.
There's a question from an online attendee. Jorge, do you want to read off your question, or would you like me to read it here?
Oh, sure. Thank you so much. I can read it. Appreciate it. Thank you so much, Dr. Winmarker. It was really
Jorge,
interesting.
we're not hearing you.
Oh,
At the beginning, it's not
hello?
effective.
Trying to hear him.
Yeah, it's a good question. So there is some baby that the therapeutic hypothermia is not efficient, and some that are. And he's asking the question if I think the brown fat that do thermogenesis is explaining the difference. So I think there is this belief that baby cannot shiver exactly for this reason, and they can shiver, in fact. So that's exactly sometimes what is written in the book, and the reality is not the same. What we have found is also, I didn't show that part, but we have measured with MRI brain perfusion also. And we did, when we did originally day 1, day 2, day 10, and day 30, we show that in fact, already by day of life 1 or 2, at the latest, you see this hyperperfusion in the brain. So it's probably that, and we are not sure why, some baby, the hypothermia doesn't work as it should, to prevent the brain damage. So is it, and it's not very clear why, because very often you have two babies with the same story, and then one doesn't have brain damage and one has, and then you don't see the difference. So some people think there is inflammation in addition that was already there. So that's true. Sometimes the mom has infection and all that, and maybe it predispose you. But sometimes we have no reason. There is all these things about genetic. Maybe you have a genetic predisposition, but that has not been tested yet. The brown fat is a possibility, but again, we didn't find a way to show that. But definitively, there is brain perfusion increase in this baby very early on. So then the hypothermia will not do anything more.
I think we have another question coming online. Oh, maybe not. That's a thank you message. Okay. Any further questions from in the room here? So I guess I was wondering, I have a clinical question. We can talk about neuroimaging as well, but more clinically oriented question. In terms of, because I mean, Jorge's question brings up the possibility of physiological differences between these patients and the efficacy of treatment. But once this moves, you did allude to the possibility of this moving to resource constrained areas where hypothermia is harder to deliver, sildenafil easier to deliver. But are there differences in terms of the causes of HIE, in countries like ours versus resource constrained countries?
There is this fact that HIE is different. There is exactly more infection and more inflammation. It's also the care that you can provide to this baby is different. So we run actually Sane Uganda, sponsored by the Gates Foundation, where we run exactly the same study, but the baby were not receiving therapeutic hypothermia. The problem is we haven't get MRI, not on day 2, but we get day 10 and day 30. We trained them. It was all started during COVID, so we trained everything by Zoom. We send one student from here there, to train, cardiac ultrasound, brain ultrasound. So we train everything. Problem is, then is somewhat utopic to repair the brain if you cannot treat well the baby, because you will make the injury worse. So,
so without the hypothermia.
Yeah, but they didn't have blood pressure monitoring, so we had to buy. They had one ventilator for the whole things. So then they had to pick which baby was getting ventilated, which often they pick our baby, but then, it's not fair to the other baby. And then once here, like you can put inotrop, you can support the kidney, you can do plenty of things. Over there, very often they couldn't do, even infection, the parents had to have money and go buy the antibiotic at the pharmacy, and if possible, bring it back. Which, here you just prescribe, give antibiotic, it's given. So it's like for all the care, even basic care, like it's missing so many resources that you should first improve probably the care of the baby. Every unit should have the minimal things to be able to take care well of the baby. And then you can see.
Then brain repair.
Yes.
So the neuroprotective
we tested, but for the one, we had some baby that had profound meningitis, which here we don't see often profound meningitis in babies. So I can give sildenafil, but if you have profound meningitis and seizing continuously, because in fact you have one anti-seizure medication, you don't have 3 like here to stop, like what you can do is limited.
So the neuroprotective side is lacking.
Yes.
What you already took for granted.
Yes.
When you started the research here.
Exactly. So I think that's the big difference,
Okay.
to move forward. It was feasible, we measured the same thing, we measured the blood, we collected the blood, they did a fantastic job. But then what you can
Basic
reach
care.
is, yes, exactly.
Interesting. Okay.
I'm wondering if you have an idea of whether the combination of the hypothermia with the sildenafil causes better outcomes than just the sildenafil or just.
Yeah. So usually clinician ask us that. So I removed that slide because I was thinking it was not interesting. But we tested that in the animal because the problem, for example, with erythropoietin, when they tested in combination, it didn't have additional effect. Okay. And then when they tested in the baby, it didn't have the effect. So we tested sildenafil and hypothermia, and it had additional effect. So the group that received both was a better outcome for the animals. So this is why we think, there is a chance we do better in the babies.
Okay, so with the combination.
Yeah. Yeah.
Now I'm going to ask a neuroimaging question.
Okay.
Because I wonder, so you've used neuroimaging as a tool of research so far, but assuming you can bring up the neuroprotective practices in the NICU on a broad basis, and that you want to add on the neuro repair benefits of sildenafil, does imaging still play a role in a routine clinical protocol? Is it, you
Yes,
know,
for me, I think so, because every baby is his own control to see if I can repair. Which I find in other study where they don't do MRI or they just check neurodevelopment. In fact, you don't know what you start with. So, like, do you really not see an effect like
Right.
erythropoietin
Okay.
study? You know, like they included all the baby cooled. We
right,
cool, half of the one we cool are mild.
right,
In all cases, they will have no brain damage. So you can give erythropoietin, it
right,
will do nothing.
right.
So we use the MRI to select
As a
what we
selection
give,
tool. Okay.
exactly. And then we use the MRI to see if we can repair the brain. So like all the things we did in animal where you can take the brain, check your cell, we are trying to find ways that with the MRI, can we see if we have this effect too in the human babies?
And does that carry over from the research steps of this work to the
Yes.
translation steps of this work, you think?
Yes, but for sure, like the hospital where we are opening, they find that complicated to do MRI on day of life too, because it's a lot of, you have to train and it moves a lot of people, it moves a sick baby.
Yeah,
So they say, like, can we remove it? And we say, no, like you didn't get it. Every patient is his own control. But if we prove it's efficient, we're supposed to enroll 120 baby. I guess if we prove it's efficient, then people will apply it, as they want.
you mentioned working with the Gates Foundation, and the Gates Foundation have also been supporters of portable MRI.
Yes.
So I think you know where I'm going with the, I mean, have they made the connection or has someone made the connection somewhere?
Yes, we nearly had a portable MRI here, but then radiology was not ready. So in the end, we were not one of the site, unfortunately.
Yep.
We wanted to have that in the NICU and not depend on anybody else, but yes, that didn't work. In Uganda, they had a site that had the portable MRI, but that was not the site that we ran the study. But obviously, I think it is great because you don't need to move the patient. For now, the quality of the images and what you can do from it, we cannot do all what we do here. Because the diffusion is good, but the DTI is not so great. You cannot do spectroscopy. But they are working on it, so I have no doubt that at some point we'll be able to do the same thing.
Okay. Very interesting. Yeah. All right. So I don't see any more questions online or in the room here. I'm going to suggest we thank our speaker again.
Thank you, Rio.
Very interesting presentation. And that brings our session to a close. So thanks everyone for attending and have a good long weekend.